Hi, welcome back to educator.com. This is the lesson on blood vessels. So when we look at all the blood vessels in the human body, there are several types. Arteries are all the blood vessels that take blood out of the heart. They tend to be thick, they tend to be very strong, very tough because you got a lot of blood shooting through them, so they need to be. Arterioles are like mini arteries that branch off of it. So think of arteries as like freeways, and then arterioles are kind of like off-ramps, and eventually you get into tinier little residential streets that are oftentimes smaller and take you to all the specific places in a neighborhood. Capillaries are like that, the smallest blood vessels that come off from arteries and physically take blood and the oxygen and nutrients inside of the blood to the cells that need them. All of those capillaries eventually come together to form venules. So the venules are taking that deoxygenated blood, which looks kind of more bluish purplish because of hemoglobin changing, and you'll hear more about that in the blood lessons. The venules take all of that blood back onto freeways, you can think of them as on-ramps, going into the veins that are going to take that blood back to the heart. And veins are also very large, but structurally a bit different from arteries. When we look at vessel structure, arteries and veins have these layers. The size of the layers relative to each other are different in the veins and arteries, but let's cover these in general first. So if we start from the most superficial part of these tubes, the tunica externa is that sheath around the outside. Sometimes it's called the tunica adventitia. It just depends on the textbook. They both mean that outer sheath. And it's going to be mainly connective tissue, and that connective tissue is very tough, very strong. You don't want it to break, you don't want blood leaking out of it. And also that connective tissue is important for attaching the arteries and veins to the tissues around them. You do not want your veins, your arteries moving around a bunch. You want them anchored and in place where they're supposed to be. So the major arteries and veins of your body, they have tissue keeping them in place. And that tissue, those fibers are going to be attached to the tunica externa. The tunica media meaning, in the middle, is going to be mainly smooth muscle. So you can see smooth muscle right here. Smooth muscle is going to be in that tunica media. And the reason why there's smooth muscle there, especially in the arteries, is you want to be able to relax and constrict or dilate and make smaller those arteries just to adjust blood flow in the body. And your blood pressure adjusts throughout the day. I'll talk about more about that in a little bit later in this lesson, but you want to be able to manipulate the size of those vessels. So smooth muscle, a very important part of the tunica media. And then more connective tissue fibers, specifically collagen and elastic fibers, are going to allow the size of it to adjust as needed. And then finally, tunica interna, also called tunica intima, just depending on which textbook you're looking in, is the most internal, deep part of the arteries and veins and the other blood vessels. And that's going to be where blood itself is moving through. It's like a nice little tubular slide. It's smooth, and it's composed of endothelium. At the smallest blood vessels, capillaries, they're just endothelium without the other layers. But all the blood vessels have that layer that's meant to shuttle blood through it. And the size of the endothelium, in terms of its diameter, changes based on how much the smooth muscle is contracting or relaxing. The lumen is the name for the internal part where blood is actually moving through. So the hollow region within the endothelium layer is called a lumen. And actually other organs of the body that have hollow chambers, like even the stomach, you could say the lumen of the stomach. But lumen in this case is referring to the hollow structure inside of vessels. When we compare arteries and veins, of course, the major difference is that arteries take blood away from the heart, veins take blood back to the heart, but structurally there are some differences too. Artery walls are generally thicker, and they need to be, because if you think about the heart beating blood out of it, arteries are taking that blood that's rocketing through, and they need to be able to deal with that high pressure of blood rushing through them. By the time you get to veins coming back to the heart, blood pressure is down close to nothing. So you don't need to have as thick of a wall. Arteries do need it. The endothelium of arteries gets folded when constricted. And this picture does a decent job of showing that. So you can see that here is the tunica externa, here's the smooth muscle of the tunica media, and you see that right here, this tiny, very thin layer, the tunica interna or tunica intima, is kind of folded. You can see that there's little folds because when an artery constricts, imagine that endothelium can't just change its size and just stay nice and smooth. It kind of gets sort of folded up when you constrict it. So oftentimes a cross section of an artery looking down through it that's currently constricted, you see this folding. And you can see that these are actually blood cells. I know they look kind of yellowish, but if you look really, really, really close at these, you would see they have kind of a pinkish look, that classic red look of a red blood cell. So the endothelium of arteries gets folded when constricted. It doesn't really happen in veins. You don't notice that. And then veins have valves. Arteries do not. Similar to the valves of the heart, the valves that connect the chambers and up to the blood vessels coming out of the heart, they're like little flaps that are kind of preventing backflow. So as blood goes through veins going back to the heart, you prevent blood from going backwards by having valves. The arteries don't structurally need valves because the pressure coming out of the heart is keeping blood flowing in the proper direction through arteries. So when we look at the sequence from artery to capillary and then from capillary to vein, when we look at all the blood that's leaving the heart, it's going to start off in elastic arteries. These are the major arteries coming out of the heart. So the aorta, the pulmonary trunk, they call it, that splits into the two pulmonary arteries going to each lung, the carotid arteries, the major arteries of your body, they're called elastic arteries. Very tough and have a high amount of blood pressure running through them. Next up, as you get into ever so slightly smaller arteries branching off from there, they call them muscular arteries. The muscular layer in there, a little bit more significant because that's where you're going to have major changes in the size of the artery. The size of your aorta doesn't really change. However, the size of your brachial artery changes. The size of the arteries taking blood to all the different parts of your body does need to change occasionally. Throughout the day it happens, and so the muscular layer in there a little bit thicker to accommodate that change. All the arteries branch off into arterioles, which just means mini arteries, and then into what are called continuous capillaries. And this is a zoom in of a continuous capillary. The way I like to think of it is, you know those metal antennae rather, where you take out the parts of the antenna so that you can extend it. It's like smaller metal tubes inside bigger metal tubes. And that's a way to think about artery to arteriole to capillary, because in an arteriole, you're actually not going to have a tunica externa. Most arterioles, if you look at them in themselves, is smooth muscle wrapped around endothelium. It's as if you've removed that inner tube from out of the thicker tube of the artery. And then when you get to capillaries, it's like just endothelium by itself. You actually don't have the smooth muscles wrapped around the capillaries. It's just that internal layer. So you're looking at just endothelial cells. And I've read that some capillaries are so thin that you have a single endothelial cell wrapped around like this, and only one red blood cell at a time can move through. That's super tiny, super microscopic, and fascinating to think about. Continuous capillaries get their name because each endothelial cell, I'm actually going to draw a line around one of these in case you can't see it. So that's an endothelial cell, here's another endothelial cell, and you find them almost like in a mosaic kind of looking pattern around the tube. The way that nutrients and gases move across the capillaries, because this is the spot where you're going to be doing that, the way that glucose, little amino acids exit the capillary is through the little connections between the endothelial cells. Same with the gases. Oxygen and CO2, etc., are going to be moving back and forth through the borders of these endothelial cells. Next up, when you look at from capillary to vein, the fenestrated capillary looks very similar to the continuous capillary, but the difference is in the endothelial cells, you would actually see little holes And these little holes in the cells themselves, these passageways, and fenestra actually means window, these little windows actually help increase the rate at which water and solutes, little charged particles, charged ions, enter and exit. So it's just a slightly different structured capillary. All of these capillaries lead into venules, which are basically like tiny veins. You're not going to see as thick of a muscular layer in venules. It's actually very hard to see. It's very thin. And you don't have the muscular thickness in a vein also. So when you get into medium-sized veins leading back into large veins, you're still going to have a very solid, thick tunica externa on the outside. But when you compare the size of the smooth muscle in an artery to the size or thickness of the smooth muscle in a vein, it's not quite the same. And you don't have that highly sort of high velocity blood running through veins. And you don't have as much manipulation of vein size at this point. But the way that you're able to get blood back to the heart, I'm going to mention in a little bit. Capillary beds, when we zoom into what's going on in that capillary network that's between arterioles and venules, it's all of the tiniest little blood vessels that are allowing nutrients and gases to exit and the wastes to come in to take back to the heart. The amazing thing is that pre-capillary sphincters, little muscular doorways leading to these different parts of the network, open and close to regulate flow. So you'll have parts of this capillary bed where blood is just consistently flowing. And then you'll have other sections that will occasionally lessen blood flow there. And it's based on individual needs. You can shunt blood, meaning direct blood in very specific ways to certain tissues more than others, depending on need. If you have a need in a certain organ for more blood at that time, you can physically manipulate what parts of the capillary beds are going to be having slightly more blood flow than others. So that's a nice adaptation to have. The distribution of blood in the body, when we look at where blood is percentage-wise in the specific arteries and sections of your body, it's amazing to see these percentages, because most of the blood at any given moment is actually in your veins in the venous system. Systemic venous system means all of the veins not associated directly with the lungs. So there's the systemic circuit, and then there's the pulmonary circuit. The pulmonary circuit is all the blood vessels going to and from the lungs, because pulmonary means lungs. So in the systemic venous system, when we look at venules, medium-sized veins, and the large veins like the vena cava, the jugular vein, most of the blood, percentage-wise, is in there. Think about how blood is rocketing out of the heart every second of your life. Blood doesn't hang around in the major arteries for very long. It kind of tends to pool in the venous system, and then it gradually is brought back into the heart so that it can be re-rocketed back into the body. In the systemic arterial system, when you look at the major arteries, approximately 13% of your total blood volume is located in the aorta, the brachial artery, the femoral artery, etc. Pulmonary circuit, all of those arteries and veins associated with the lungs, even all the capillaries, slightly less than 10% of your total blood volume is located in there. The heart, about 7%. Blood doesn't stick around in the heart for very long. And then the systemic capillaries, all of the capillaries, amazingly, all throughout your body other than the lungs, 7%. That might seem really low, but keep in mind, capillaries, very, very, very narrow, very thin, oftentimes microscopic blood vessels. And here's an amazing fact. If you took just the capillaries, every single capillary in your body, even the capillaries of the pulmonary circuit, and you cut them all up and put them end to end in one solid line, it would be over 25,000 miles long, which would almost stretch around the earth. That is incredible to think about. There's a lot going on in our body. Blood pressure. Blood pressure is something that's typical for an EMT, a paramedic, a doctor, or nurse to measure. And how do we get the numbers of blood pressure? What does it mean? When you put on the blood pressure cuff, the sphygmomanometer is the proper term, with the valve and the gauge and all that stuff, you're getting a certain number. And I'll tell you how you get that in a sec. But the actual blood pressure calculation is cardiac output times peripheral resistance. So a reminder of what cardiac output is. That's stroke volume, the amount of blood exiting the heart with each ventricle contraction in milliliters, times heart rate. How many times is the heart contracting per minute? So that's going to give you the amount of blood that's exiting your heart. And peripheral resistance has to do with how narrow are the blood vessels that the blood is being shot through. The more constriction, the tinier we make the blood vessel, the more the resistance. Think about a hose. If you have a hose and water is coming out and you want the water to come out a lot faster, you put your thumb or finger in front of the opening and you make that opening smaller, and then it goes out at a higher velocity. It's the same concept. So yeah, the more the constriction, the higher resistance. That means the more the blood is pushing against the sides and rocketing much faster through. So those two together are going to determine blood pressure. So one way that blood pressure could rise is just by having the blood vessels narrow. Your heart rate could stay the same, but if your blood vessels narrow and get tinier, that's going to increase your blood pressure. Conversely, your blood pressure could go up if your blood vessels stay the same diameter, but your heart increases. So it's both. If your heart rate goes up, stroke volume, or peripheral resistance, any of these things could make the blood pressure go up. The two numbers are systolic and diastolic. Remember, if you saw the heart lessons, systole is contraction of the ventricles. You could also have systole of the atria, but here we're talking about ventricles, because the ventricles contracting is what's getting that blood out through the blood vessels. Systole has to do with that highest level of pressure. So the systolic pressure has to do with, hey, the ventricular contractions, what kind of pressure is that producing in the arteries? Diastolic is the opposite end. That's the lowest number that relates to the relaxation of the ventricles. Healthy, or sort of the common blood pressure you hear about, is 120/80. That's the systolic number over the diastolic number. So this is the range of pressure in whatever artery you're measuring, and usually has to do with an artery like the brachial artery. So putting a sphygmomanometer on this part of the arm, the first thing you do is you would attach the cuff, this little band with Velcro on it, and you have this gauge here that tells you the numbers, and then the little bulb that you squeeze. So you close the valve, and then when you squeeze, you're putting air into the cuff and it gradually tightens. So what you're doing is you're tightening it so much, and you would go above something like 160 or 170. You want to go above what you think the blood pressure is going to be, because you want to make it so pressurized that you actually temporarily stop blood flow through that artery. And then you gradually open up the valve, you let the air escape, and you gradually let the cuff just kind of relax. And the first time in the stethoscope, the little pad is going to be resting on the artery, the first time you hear a heartbeat, you look at the gauge, and whatever number it is, let's say it is 134, that's your systolic. Because that's the amount of pressure it took for blood to kind of conquer the pressure that you were exerting on here. So whenever there is just slightly more blood pressure to physically push blood through compared to the pressure that you were applying on here, that tells you the max pressure running through that blood vessel. If it's 120, that's pretty healthy. If it's 170, that's pretty high. Really high blood pressure like that tells you that this person probably has narrowing of arteries, and that's not good in the long run in terms of heart attack risk. Then you continue this process of listening, dropping the pressure. That little needle is going to keep falling on this gauge, and the last moment you hear a heartbeat, let's say it's when the needle reaches 80, that tells you the diastolic. That's the lowest amount of pressure going through the blood vessel. It could be 60, it could be 92. And the distance between the systolic and diastolic tells doctors a lot about your blood pressure, heart health, etc. So 120/80, That's normal. Very few people are going to experience that blood pressure throughout the day. Right now, since I've been talking to you on camera, my blood pressure is probably higher. Yes, I'm sitting down, which tends to make blood pressure drop a little bit, but I'm doing a lot of activity, gesticulating and moving of my mouth and such. My blood pressure is probably higher. Throughout the day, blood pressure changes. You could take your blood pressure in one instance sitting down and it could be 124/78, and then you could feel like you've done nothing and not changed your behavior, and then 5 minutes later it could be 132/86, and your blood pressure does fluctuate based on your needs at those moments throughout the day. Typically, when you stand up, when you do more, your blood vessels are going to constrict a bit to help rocket blood a little faster to the skeletal muscles. But it certainly depends on the person, and it certainly depends on what you're doing. So how does blood get back through the veins? If you have a lot less blood pressure by the time you get to veins because you're so far away from the heart, how does blood get from the bottom of your body, from all the way down in your feet, back up to your heart? Since veins don't have that thick muscular layer, there's got to be another way to do it. One of the ways is the valves. So the valves in the veins, they prevent blood from going back. And you can see from this here, this little circle is saying, hey, it's open, blood's gonna go through. And then occasionally the valves they close shut so that the blood that's above it can't go back down. You want to keep it going back up to the heart, especially in the vena cava. That's a long journey in the inferior vena cava back to the right atrium. Another way that you do it is skeletal muscle contractions. Your veins tend to be next to skeletal muscles. And when you move your legs, move your arms, you're contracting and relaxing skeletal muscles that are neighboring these veins. And the skeletal muscle contractions and relaxations, they kind of squeeze on the veins, and it physically pushes blood back through and past valves, and then eventually pushes it farther and farther up. This is why being active, being physically active and moving around is important. You may have noticed that if you're sitting on an airplane for 5 hours and you don't do much, you're probably going to feel sore, and it's actually not good for you. You're more likely to get a clot if you keep joints in one fixed position for a while, because there'll be certain arteries and veins that have been kind of compressed, almost like squeezing a straw, and you can get not proper circulation. So they recommend, if you're on a long flight, let's say you're going 18 hours to another continent, get up a few times and walk around the cabin of the plane. Get that blood flowing really efficiently. People who don't do a lot of physical activity throughout their life are going to tend to have circulatory problems, whether it's edema or other problems with blood pressure, etc. So moving skeletal muscles helps get that blood through veins. Regulation of blood vessels in terms of peripheral resistance, how much they're constricted or relaxed. You're able to notice, without even thinking about it, through baroreceptor reflexes. In the carotid sinuses and aortic sinuses, in the physical blood vessel of the carotid arteries going up into your head and the aorta taking blood out of the heart, you have the ability to notice the amount of pressure going through those particular arteries. And that communicates with your brain, and depending on what's going on, what the needs are, those signals can stimulate some manipulation of your blood pressure. For instance, antidiuretic hormone, ADH, is one of those hormones that's going to keep water in your body, so that you're not making as much urine, you're not urinating as much. Now, the way that ADH actually plays a role is if there is a drop in blood volume. For instance, let's say you have an internal bleed, and that would be terrible to have, but if you have an internal bleed where blood is exiting blood vessels, that would stimulate your brain because of a drop in the pressure. It's going to stimulate release of ADH so that you actually will constrict the vessels so that you don't have quite as much blood sort of going to that area and exiting. because of this hemorrhaging, because of the blood leaving the blood vessel. So if there's a drop in blood volume, also if you're dehydrated, if you don't have enough water in your body, you're going to have less blood in your body, slightly less, and that's going to stimulate the release of ADH so that you're not urinating those fluids out. Angiotensin II can actually have a lot to do with ADH levels as well. That can stimulate the release of ADH, but when you are thirsty, angiotensin II has a lot to do with blood pressure manipulation. If you're thirsty, you probably don't have as much fluid in your body as you're supposed to have. Erythropoietin is basically a hormone that relates to the production of red blood cells. Erythropoietin is going to stimulate the making of red blood cells, and they're going to come out of your bone marrow into your blood vessels. And that's supposed to happen every second of every day, but the rate at which erythropoietin is actually causing you to produce red blood cells is going to vary. If you have too much red blood cells, your blood is physically thicker, and there's going to be more stuff pushing on the inside of your arteries and veins, and that's going to increase the blood pressure. The interesting thing about erythropoietin is that certain pharmaceutical companies have made drugs that assist with this process of making red blood cells. My dad used to work for a company that made a drug that causes you as a patient to produce way more red blood cells than you normally would. And they made it for kidney dialysis patients, and that was important for them. But if you are a cyclist in the cycling world or in other sports that involve a lot of endurance, you can do what's called blood doping, and it's not recommended by doctors, and there's obviously ethical and moral problems with that, but blood doping is, it was in the news. When cyclists are using this drug, when they're perfectly healthy and don't really need more red blood cells, they're adding more red blood cells to their blood vessels so that they can have more endurance. The more red blood cells, the more oxygen you're carrying around your body, the more oxygen you can supply to your skeletal muscles. The problem with that is that thicker blood over time can cause health problems. You're more likely to get a clot. You're more likely to have some really bad health problems happening from abusing that. Here's some examples of arteries and veins. There are so many. I'm just going to highlight a few of them. The aorta has come up a lot. That is the major, thickest, largest artery coming out from the left ventricle, taking oxygenated blood all over the body. That branches off into slightly smaller arteries like the carotid arteries. These carotid arteries are taking oxygenated blood up into your brain. And the carotid artery, you can feel your carotid pulse right over here. The brachial artery is a major artery going through each arm, and then the femoral artery corresponding to the word femur, the femoral artery, these red ones right here, taking oxygenated blood into the legs. On the other side, you have major veins, the vena cava, already mentioned these, the vena cava, the inferior vena cava, and the superior vena cava take deoxygenated blood into the right side of the heart. The jugular veins, those are taking deoxygenated blood back to the heart from the head. You may have heard about getting hit in the jugular. That is in the neck region. The brachial veins, corresponds to the arterial word, brachial veins, and femoral veins. They're just going to do the exact opposite in terms of directional flow, taking deoxygenated blood back. And more often than not, you're going to see veins being more superficial than arteries. Arteries tend to be deeper, and that's a good thing. An arterial bleed is going to be more likely to result in death or loss of a limb or loss of tissue, the life of the tissue, because arteries have blood rocketing through them. They're closer to the heart. Venous bleeds are bad too, but they tend to be a bit slower. You can see if you look closely at my forearm, I have these blood vessels. You can see these blue blood vessels are veins. They're going up a bit more superficially compared to the larger veins that are deeper, but the ones that you see on the surface of your skin, they tend to be veins. And then finally, the hepatic veins. The word hepatic is associated with the liver, like the word hepatitis is a liver infection. Hepatic veins have to do with taking blood from the liver, and they'll connect back into the vena cava, taking blood back to the heart. Pulse sounds. When I was trained as an EMT, there are two classic areas that you take pulses. The first one is the carotid pulse. You can see from this picture, this individual looks unconscious. They probably are, because I remember in the classes they said if you come across a patient in the field who is conscious, they're physically looking at you, physically aware of their surroundings, you don't go for their neck to take their pulse, because generally when you reach for someone's neck, they get a little disturbed by that. So if someone's conscious, they recommend you take the radial pulse. And here is where part of the radial artery is, associated with the radius bone, which is on the thumb side. Ulna is over here. So the proper spot here is if you find the thumb and go just down here, you can feel there's like a little like tendon here. It's pretty hard. And then right on the side of it, there's like a little well that I'm finding right here. And if I just press in a little bit, I can feel it. And they ask you to use these because there's actually a separate little pulse in your thumb that could be a little confusing if you're trying to take someone else's pulse. So carotid pulse on the side of the larynx, if you press it enough, yep, I'm feeling it right now. And it's on either side because there's a carotid artery on both sides. There's obviously a radial artery on both hands. The femoral artery is, you can usually find that pulse just on the interior or medial side of the thigh. The popliteal pulse, that's near the knee, corresponding to that artery. The temporal pulse, it's kind of odd to think about, but like right here, I can actually feel a tiny little pulse because you do have these temporal arteries extending from the carotid ones going through that part of the head. And then the dorsalis pedis is actually on the foot. But the classic two, carotid and radial. And you are literally hearing blood shooting through, corresponding to each contraction of the ventricle. And finally, some blood vessel conditions and disorders. Hypertension and hypotension. Hypertension means high blood pressure. Hypotension, low blood pressure. I am slightly hypotensive. On average, I have a lower blood pressure than the average person. So typically when I go to the doctor or go to donate blood, the blood pressure reading will be something like 118/76. That's very normal for me. In other people, that would be very low because they might be hypertensive. And hypertension over time tends to be worse because the narrowing of the blood vessels over time is going to make it more likely that you're going to get constricted blood flow to the heart, and a formation of a plaque inside of the blood vessel is going to further that constriction in terms of getting blood through. Another problem with hypotension, though, is that the more hypotensive you are, the more likely it is that you're going to pass out. If I am sitting or laying down for a long time and I get up really fast, my body doesn't have enough time to adjust adequately to getting the blood vessels constricted enough to shoot blood higher up against gravity. So I can get this like kind of 1 or 2 second brief blackout where it's like, for a second, it's like I can't see. I have not passed out, but if my blood pressure was significantly lower, there wouldn't be quite enough blood going to my head if I stood up fast. So hypertension, hypotension, high, low blood pressure. Arteriosclerosis is tends to be a hardening and lessening of the diameter that's in a blood vessel. So over time, from the formation of plaques, buildup of fatty tissue, fatty streaks with dead white blood cells that have tried to deal with that, and it's a progressive process over time. I'll tell you more about that with blood. Over time, arteriosclerosis causes a narrowing of arteries. And then atherosclerosis is the long-term one where you're most at risk for having a heart attack or a stroke, constriction of blood flow to the heart or other parts of the body. And the best ways to avoid this, like you hear all the time, is try to have a diet that's lower in saturated fat and stay active. Edema is the pooling of fluids where they don't belong. And that's related to circulation because if you're not circulating fluids effectively, they are going to pool. They are going to end up where they don't belong. And one example of that is cankles, if you've heard of the term cankles, where usually it's in older people where their calf muscle, the gastrocnemius, and where it connects with the ankle, it almost looks like their calf and ankle are the same size. That's edema in the leg, and that does correspond to lack of proper circulation over time. An aneurysm is when you have a slight tear or break in the wall between where the lumen is, where blood is flowing, and then you have blood gradually leaking in to where you have the tunica media. And so that blood will end up pooling in here, and eventually you'll get a little bulge where the wall, the tunica externa, keeps getting weakened because of that excess blood, and it will kind of balloon out. And eventually aneurysms can burst, and that can cause death depending on where the aneurysm is. Sometimes it happens abruptly. If someone gets an aneurysm within their head, that can lead to death very quickly, and there aren't a lot of signs that tell you an aneurysm is developing. Oftentimes they're discovered because someone goes in for another health problem. Maybe they had chronic headaches, or they feel fatigued or something, and they'll do tests, and something like an MRI will show that they have an aneurysm, and they'll do surgery to remove this and repair the blood vessel wall before it bursts. Hemorrhaging has to do with internal bleeding. Having blood leaking out, that is a hemorrhage. So a burst aneurysm would lead to hemorrhaging. A thrombus is the formation of a blood clot that is solid and in some particular blood vessel. And a thrombus is supposed to occur when you want to have that clot, when you want to stop blood from exiting a certain spot. But if a thrombus stays, that's not a good thing. You want the clot to be disintegrated once you have the repair of that blood vessel wall over time. And some blood vessels, when they do rupture, like the major ones, the large ones, they don't repair themselves. So that would need surgery, emergency surgery. But a thrombus, that's an abnormal blood clot, and that does restrict blood flow. If that thrombus gets dislodged and starts flowing through blood vessels, that becomes an embolus, and that ends up resulting in an embolism. One example is a pulmonary embolism. If that dislodged blood clot gets caught in part of the lungs, that can kill a person. Varicose veins. Here's an image here. Here's a normal vein where you got the valves and you got blood flowing properly. And this is an image of what that varicose vein looks like when you zoom into it. And they tend to be most noticeable on the lower parts of the legs. When you have a weakening of the vein wall and abnormal functioning of the valve, if the valve isn't working properly, you can end up getting this enlarged, deformed vein. And yes, it's not very attractive. Some people get laser surgery to make it so that they're not as noticeable. And once again, being active and having a healthy diet is going to minimize the chances of this happening, but I've heard that there are genetic factors associated with certain people developing varicose veins over time more than others. Hemorrhoids. This would be kind of like varicose veins, but in a particular part of the body. If you have an enlargement of blood vessels in the rectum, near the anus, near that opening, that's hemorrhoids. One of the ways they happen is when people are on the toilet doing number 2 and they're pushing. Over time, you're more likely to develop hemorrhoids, because hemorrhoids is an enlargement of those blood vessels right next to where that fecal matter is coming out. And a sign that you have hemorrhoids is blood on the toilet paper or blood in the toilet. And if you want to reduce the chance of getting hemorrhoids or make them better when you do notice that blood, drink more water, eat more fiber, because fiber is going to make your bowel movements, your stool, not as hard. It's going to minimize the chance of that irritation. So water, more fiber, and stop pushing on the toilet. Take some reading material. Just breathe, just relax, and it'll come out when it's supposed to come out. Hemorrhoids can be surgically removed, but that's an operation some people choose not to get. And so, like I said, water, fiber, stop pushing on the toilet. That minimizes the effect or the occurrence of hemorrhoids. Angiogenesis is the forming of blood vessels. Angiogenesis happens because of tumors. So when you have a tumor developing in an organ, interestingly enough, a cancerous tumor will secrete certain chemicals, certain compounds that will encourage angiogenesis. And that's one of the evil things that tumors do. When they encourage blood vessels to grow more into them, they end up growing more rapidly. And that's one of the things that cancer researchers are trying to conquer. Angiogenesis can also naturally happen more so in certain people within the heart. Some people do, over time, naturally make blood vessels that bypass a part of a coronary artery that has restricted blood flow. So yeah, thanks for watching educator.com.